Look here lastly at the lung surfaces. So the lung surfaces and the features of the lungs are important in understanding how they sit in the thoracic cavity as well as their function. So we have the costal surface of the lungs, which are intimately attached, not attached, but they come into contact with the ribs. This is the anterior surface of the lung that sits against the thoracic wall via the pleural connections and are in touch with the lungs, with the ribs, excuse me. Then we have the mediastinal surface. This is the surface of the lungs that's making contact with the heart. This is where we have both lungs at the middle, meeting at the middle, and then the heart is in the middle mediastinum, intimately covered by the pericardium, but making contact with both parts of the mediastinal surface of the lungs. Then we have the diaphragmatic surface, and the diaphragmatic surface is going to rest on the diaphragm. This is the dome-shaped region because of the shape of the diaphragm, especially on the right lung because of the prominence of the liver on the right side. And lastly, we have the apex. The apex is going to be the pointed projection that projects up into the cervical region, up into the neck, and is going to be covered by the cervical pleura. So the parts of the lungs are going to be covered by the corresponding parts of the pleura. So the cervical covers the apex, the costal covers the costal surface, mediastinal covers the mediastinal surface, and the diaphragmatic covering the diaphragmatic surface. Looking at the features of each lung. Now, it's really important to look at how the lungs differ. You should be able to look at a lung and determine if it's the right lung or left lung based upon the number of lobes, the shape, the features, and then the fissures that divide the lobes. So the right lung is larger, it's heavier, it's usually shorter and wider. It has 3 lobes, superior lobe separated by a horizontal fissure from a middle lobe, and then the middle lobe separated by an oblique fissure from the inferior lobe. So it has 2 fissures and 3 lobes, right? It's going to be larger because the heart is shifted towards the left. So because the heart helps to occupy some of the left side of the thoracic cavity, the right lung ends up being slightly larger than the left lung. However, it's going to be shorter and wider because it's kind of pushed up into the thoracic cavity because of the prominence of the liver on the right. So what we're going to see is that the right lung, although it's bigger, is shorter and kind of stuffed up more horizontally in the thoracic cavity. The left lung, which has more space, is a bit more horizontal and more narrow. All right. So here's the left lung. And again, just looking on the shapes, you can see this is longer, more horizontal. It's smaller. It has 2 lobes, 1 fissure. So both lungs have an oblique fissure, and the left lung has only an oblique fissure. The superior lobe is going to be larger and on top. The inferior lobe is going to be smaller and really towards the bottom and towards the back, right? It's really hard to auscultate or listen to the inferior lobes from the front of the chest. We're also going to see the lingula. And the lingula is the flap-like projection that is thought to be the remnant of what used to be the middle lobe on the left, but it is unique to the left lobe, and it's going to sit in the recess where the heart is found, the costal recess or the costal margin, where we have the heart sitting on the left side. Okay, let's go ahead and take a pause. All right, so let's begin by looking at some of the neck muscles here. First up, we have the sternocleidomastoid. And the sternocleidomastoid, the name here is going to help you with the connections, the origins and attachments of this muscle. So sternocleidomastoid originates from the manubrium of the sternum, the sternal head, and then the clavicular head from the clavicle. And then it's going to have its third attachment at the mastoid process of the temporal bone. So that is going to help in the name, right? Sternocleidomastoid. And the function of this muscle is going to be with flexion of the neck. It's going to help with lateral neck flexion, as well as a forward neck flexion in terms of bilateral action. So that is the sternocleidomastoid, one of the prominent neck muscles, and really important in helping us turn, with flexion lateral and forward flexion of the neck. Now, if we strip away the sternocleidomastoid, we're going to encounter a bunch of strap muscles. These are referred to as hyoid muscles. We actually have a group that's called a suprahyoid group. So the muscles that are above the hyoid are called suprahyoid, which are these groups, these muscles here. These we're not going to be too concerned about in this class, but the infrahyoid ones we are going to be more concerned with. These are the ones below the hyoid bone. And then here's the hyoid in the middle for reference. So the hyoid is very important in terms of stabilizing these muscles. And these muscles help with aspects of neck movement, aspects of movement of the mandible. You can see some are attached to the mandible and the temporal bone, but also involved in moving the mandible for speaking, chewing, swallowing, and deglutition. So really lots of different types of actions involved around the neck region. Also helping to stabilize the muscles of the larynx, which are involved in voice production, speech production. So a lot of, small fine-tuned functions in terms of movement, speech, chewing, that are helped by these strap muscles. So let's look at the muscles individually. And again, we call them strap muscles because they have sort of a ribbon-like structure. If you look at them, they're thin and long, and they do look like straps that help secure some of these laryngeal structures and bones. Now, their names, again, are going to help you know their origins and insertions. So the sternohyoid is the first one, and it's the most superficial. So if you were doing a dissection of the neck and you took away the skin, took away the larger platysma muscle, took away the sternocleidomastoid, this is going to be one of the first muscles, the first strap muscles that you see at the anterior surface of the neck. It's going to be covering over the thyroid, the trachea, and the other deeper muscles. So it's superficial, and then it's also medial, closer to the midline, right? Next, we have the sternothyroid. And sternothyroid is going to be the second muscle. This is going to be deeper than the two superficial ones. And again, the name here is going to help. So it's going to go from the sternum to the thyroid cartilage, whereas sternohyoid goes from the sternum to the hyoid bone. So sternothyroid is going to be deep, and it's going to be inferior and more lateral. Then we have thyrohyoid. Thyrohyoid is the smallest. It's a very short muscle, and it's confined to the thyroid cartilage. So it's on the anterior aspect of the thyroid cartilage. And again, its name here, thyroid cartilage to the hyoid bone. So a very short distance on the anterior surface of the thyroid cartilage. And it's going to be deep to the superficial muscles, but superior. Lastly, the omohyoid. And the prefix omo actually means shoulder. And so one of the attachments of omohyoid is posteriorly onto the clavicle and then superiorly onto the hyoid, hence the term omohyoid. Okay, so it's the only strap muscle that curves posteriorly onto the scapula and then has another attachment superiorly onto the hyoid. So just to go over those again, here's an anterior view. In this view, the sternohyoid has been cut. So notice sternohyoid would be the most superficial and the most medial. So sternohyoid, right next to that, also superficial, we have omohyoid going back towards the scapula. And then deep to that, we have thyrohyoid being the shortest of the four. And then inferior to that, we have sternothyroid being the deep one, but also more inferior. Okay. Let's look at the intercostal muscles, and the intercostals are found in between the ribs. So they're kind of digitating in between the ribs. First, we have the external intercostals, and these have an orientation down and out. And the external intercostals are important, excuse me, down and in, not down and out, down and in. And the external intercostals are important in elevating the ribs during inhalation. So while we are bringing air in, opening up the shape of the thoracic cavity, the elevation of the ribs, kind of like a bucket handle, is what's really important for inhalation or bringing air in. Whereas the internal intercostals are going to help depress the ribs, are going to be activated during exhalation. So the internal intercostals are going to have the opposite orientation down and out. External intercostals down and in, internal intercostals down and out, okay, in terms of the orientation of the fibers. Now, if we look more closely at the thoracic wall and we take those two layers away, next we have the innermost intercostals. These are best seen from an internal view, and they're going to be running deep and internally to the internal intercostals. And these don't have as much of a clear function with respiration, but they do have an accessory function in helping the internal intercostals in their function of depressing the ribs. Next, we have the transversus thoracis. This is another muscle found on the inner surface of the thoracic cavity, and it's spanning across the sternum to the adjacent ribs. Now, the transversus thoracis also doesn't have a clear function in respiration, and it also is found in varying degrees. Now, we can see some cadavers or some anatomy that has a very large and prominent transversus thoracis, and then some anatomy that has a very small, almost menial vestigial muscle, which indicates that it doesn't have a very clear or important function. And then lastly, the diaphragm. Now, the diaphragm is the most important muscle of respiration. It is the muscle of respiration. So it is going to help flatten out and increase the size and shape of the thoracic cavity. And then when it goes back to its dome shape, it's going to help with exhalation or, reducing the size of the thoracic cavity. So the diaphragm is the most important muscle. It's innervated by the phrenic nerve, and it is actively involved in changing the thoracic cavity shape, which is involved in the inflation and deflation of the lungs, right? Gas exchange. Moving on to other thoracic cavity structures. So we have the intercostal structures, the intercostal vessels, the arteries, nerves, and veins. These can be seen running along the inferior border of each of the ribs in this trio. And we're going to find them in this order from superior to inferior. The vein, then the artery, then the nerve. So the mnemonic here is VAN, V-A-N, in terms of the superior to inferior order. They're usually going to be found in between the internal intercostals and the innermost intercostals on the inner surface of the thoracic cavity and of these muscles. Okay. Let's look at some other vasculature in the region. So vessels of the neck would be the carotids. And the carotids are branches of the aorta and the brachiocephalic trunk. So on the left side, the carotids come as the common carotid, which is a branch of the arch of the aorta. Here's the arch of aorta. Here's the common carotid in the middle. And then here's the carotid bifurcation, where it divides into the internal carotid, which goes posterior and deep to enter the brain. This is the major supply to the brain. and the internal aspects of the skull versus the external carotid, which goes anterior and superficial, and this is the main supply to the face and skull, right? So the external carotid does the outer blood supply, and it's going to be more medial, but more anterior and more superficial, whereas the internal carotid is going to be more lateral, but more posterior, and then that is going to run deep to enter the brain. Okay. Now, the difference here, as I mentioned, on the left, the carotid comes from the common carotid, which comes from the arch of aorta. On the left, the carotid comes from the brachiocephalic trunk. So slightly different anatomy from left to right. Next, we have the jugular vein. And the jugular vein, we have, again, right and left. These are going to be found running in a trio within the carotid sheath. There is the common carotid artery, the internal jugular vein, and then the vagus nerve. So that is found as a trio in the carotid sheath that is running through the neck. Now, the jugular veins also have the external jugular, so internal jugular vein, and then we also have the external jugular, which is much more superficial. External jugular is usually found on the surface of sternocleidomastoid. So we usually have to go more superficial to find external jugular, and then slightly more deep in the neck to find the larger internal jugular. External jugular is going to drain the face and scalp, kind of the territory of the external carotid. And then internal jugular drains the deeper neck structures, the thyroid, the larynx, the sinuses of the brain, the venous sinuses of the brain. And so that is going to be the deeper structures, which is the territory of the internal carotid as well. So that is the division of the jugular and kind of how they drain different territories of the head and neck and face. Let's look at the pulmonary blood supply and the pulmonary vessels. So we want to think about the blood vessels, arteries versus veins, and we want to kind of remind ourselves of that naming convention. So arteries are vessels that take blood away from the heart. Veins are vessels that bring blood back to the heart. So we don't want to think about these terms, in terms of oxygenated versus not. We want to think about it in the direction of flow from the heart. So on that basis, we have the pulmonary artery, which is, although it's carrying deoxygenated blood, it's going away from the right ventricle and it's taking that blood towards the lungs. It's going to start with the pulmonary trunk and then divide into right and left pulmonary arteries, and that is going to take blood into the right and left lungs respectively. So we have we have a left pulmonary artery and a right pulmonary artery going to the lungs respectively. We also have the pulmonary veins. Here we have 4 pulmonary veins that are coming back to the heart, and these are carrying oxygenated blood, although they're called veins. There are 4 of them, 2 superior coming back to the upper parts of the left atrium, and then 2 inferior coming back to the lower parts of the left atrium. So notice that they're all dumping into the left atrium, which is at the upper back part of the heart. So the superior posterior aspect or chamber of the heart, which is where those 4 veins will bring back oxygenated blood. Okay, so 2 arteries and 4 veins that are in relation to the heart chambers and the lungs. Let's talk about some of the other venous drainage of the thoracic cavity. So when we look at the intercostal veins, the venous structure that drains blood from the intercostals, as well as from some of the other related thoracic structures, is the azygous system. And the azygous is the vein on the right side of the thoracic cavity, whereas the hemiazygous is the vein on the left side. So this creates this H-like configuration where the hemiazygous drains the left side along with a much smaller accessory hemiazygous. So here's the accessory hemiazygous and the hemiazygous, Accessory drains the upper part on the left. Hemiazygous drains the lower part on the left, and then they both cross the midline to dump into the main azygos. The main azygos on the other end drains the entire right side of the thoracic cavity. So that means that there's only one azygos, there's only one hemiazygos, and these are unpaired structures, okay? But they're draining different territories, and then they're going to communicate ultimately to the azygos, which then communicates into the superior vena cava as it ascends and dumps that venous blood into the larger vein. Okay. So what I want you to really know here is the difference in the name and then kind of where they're found, right? The accessory being on top, hemi being on the bottom, on the left, and then azygos being on the. We also want to look at some of the nervous structures here and differentiate them from each other. So we have two major nerves that are descending into the thorax through the neck, the vagus and the phrenic. The vagus is one of our cranial nerves, cranial nerve 10. It's involved in several structures. The vagus does a lot of things. It innervates the laryngeal muscles. Right here is the vagus nerve descending through the neck. It's going to give off several branches that innervates the larynx. It's going to give off the recurrent laryngeal branch. So here's the recurrent laryngeal that is going to wrap around the arch of aorta, and then it's going to go back up to reoccur, hence the term, and innervate other structures in the larynx. The vagus is going to also give parasympathetic innervation to the heart, to the lungs, and to the stomach, esophagus, etc., to the foregut or upper gastrointestinal structures. Now, what's important about the vagus is that it's going to ascend in the superior mediastinum, and then it's going to end up being in the posterior mediastinum. And that is very different from where the phrenic is found. So the phrenic is running more laterally. So here's the vagus more medial, and then here's the phrenic more lateral. Phrenic is going to descend lateral, and it's going to run on the outer surface of the pericardial sac of the heart, and it's going to be found in the middle mediastinum, as opposed to the vagus, which is found in the posterior mediastinum. Phrenic is also going to innervate the pericardium as well as the diaphragm, right? The phrenic is going to give innervation to the diaphragm, which is motor control to the diaphragm. So let's say we had an injury or surgery in the neck that affected the diaphragm. This patient would wake up with the inability to breathe or hemiparalysis of one half of the diaphragm. And that could quickly become fatal as it could affect respiration. Alternatively, if we had a patient wake up with a vagus nerve injury in the neck, that could result in hoarseness of voice. They would have difficulty speaking because of paralysis of the laryngeal muscles, which would be hoarseness of voice. So two different nerves in the same vicinity, they have two different functions. However, they can both be injured with thyroid surgery, any emergency airway surgery, tracheal surgery, or anything like that in the neck. Okay. Next, we want to think about the sympathetic trunk. This is the sympathetic innervation to heart, lungs, most of the thoracic and abdominal viscera. It's going to be found in the posterior thoracic wall, the posterior mediastinum, and it's running along adjacent to the vertebral column and found on both sides. So here's a sympathetic chain on the right and sympathetic chain on the left. Now, this is where we have the ganglia, the autonomic ganglia, where the preganglionic neurons synapse, and then the postganglionic neurons arise, and then they continue out their respective organs. So we talked about this when we looked at the structure of the autonomic system and the neurons that are involved, right? These sympathetic neurons. And so this structure represents the ganglia where those two neurons can have their synaptic connection, right? The autonomic ganglia. Next, we have a lymphatic structure, the thoracic duct. So the thoracic duct is going to be the major thoracic lymphatic structure in the thoracic cavity. It's going to drain the left side of the head, upper extremity, and the entire lower body, both limbs, the entire abdomen, pelvis, etc. So all of the drainage that ascends from the lower parts of the body is going to travel to the thoracic duct, which is ascending anterior to the vertebral bodies, and then it's going to dump into the venous system at the venous angle. So it's bringing all of that lymphatic drainage and helping it dump back into the venous system on the left. The alternative structure for the right is the right lymphatic duct. And the right lymphatic duct only drains a very small part in terms of lymphatic drainage. It drains the right upper limb, right thoracic cavity, and right head and neck. And that will drain into the right side of the venous, jugular vein by way of the right lymphatic duct. So it's really important to think about how the lymphatic drainage is separated, with most of that drainage via the thoracic duct entering the left side of the jugular vein and subclavian vein.